All right, we're talking about one of the most common drugs on the planet, metformin. But today, we're zeroing in on how it can cause a really lethal complication, metformin-associated lactic acidosis, or MALA. Think of this as your high-yield, gotta-know briefing for managing this emergency. Let's jump in.
So let's just cut right to the chase with this question. You have a patient on metformin, so do millions of other people. It's a safe drug, right? So when does that switch flip? When does this cornerstone of diabetes care become a flat-out life-threatening emergency? That's exactly what we're about to break down.
And here's our game plan. First, we're going to dig into the hidden mechanism, the real why behind MALA. Then we'll talk about the perfect storm of factors that sets the stage. We'll cover the alarm bells you need to listen for, your immediate action plan when you hear them, and then wrap up with the modern prescribing guidelines.
Okay, let's start with that hidden mechanism. I promise you, if you can really grasp the why behind this, everything else about managing it will just click into place, especially when you're under pressure. It all goes back to something deep inside the cell. We're talking about the mitochondrion. Yep, the powerhouse of the cell. This is where the body makes its energy currency, ATP. And it's exactly where metformin does its most important and its most dangerous work. So we all learned that metformin stops the liver from making too much sugar. And that's true. But the secret to understanding MALA is this. Metformin directly poisons complex I of the electron transport chain. It essentially jams a wrench in the main engine of the cell. So what happens when you jam that engine? Well, the cell can't use oxygen like it's supposed to. It has to switch to its emergency backup generator, which is anaerobic metabolism. When that happens, pyruvate can't go down the normal path, so it gets shunted and converted into lactate. And there it is, step one of the disaster. But, making more lactate is only half the story. Normally, the liver is a champ at cleaning up lactate. It just recycles it back into glucose through the Cori cycle. But here's the kicker, the cruel irony. The pathway the liver uses for this cleanup, gluconeogenesis, is the exact same pathway metformin is famous for blocking. And this, right here, is the core concept you have to remember. It's a devastating double hit. Metformin makes the body produce more lactate, and it blocks the body's main way of getting rid of it. This is why the lactate level can just absolutely skyrocket. Okay, so we've got the mechanism, that nasty double hit. Now let's talk about what has to happen in a patient for this to become a full-blown crisis. Let's talk about the perfect storm. The number one most important factor here is kidney function. See, metformin isn't broken down by the body at all. It relies 100% on the kidneys to get excreted. So if your patient has CKD, they can't clear the drug. It just hangs around, building up to toxic levels, and that means even more potent poisoning of those mitochondria we just talked about. And this sets off a clear, predictable cascade to crisis. First, the drug builds up because of the bad kidneys. This leads to massive mitochondrial shutdown and lactate production. Then, the liver, which is also affected by metformin, can't clear the lactate. And to top it all off, the failing kidneys can't clear the lactate either. It is a total system breakdown. This means you have to have your radar on high alert for certain red flags in a patient's chart. Be extra vigilant with patients who are already kinda on the edge. The ones with heart failure, a history of shock, high sepsis risk, or chronic hypoxia. All these conditions already push the body to make more lactate, so they're starting out with a much higher baseline risk. And then you've got the acute triggers, the events that can push a stable patient right off a cliff. I'm talking about sepsis, any kind of shock, a new hypoxic event, or even getting IV contrast for a CT scan, which can cause an acute kidney injury. The take-home message here is simple and non-negotiable. You must hold metformin in these acute situations. Okay, so your patient is sick. You're worried, you think it might be MALA. How do you confirm it, and how do you do it fast? Let's talk about reading the alarm bells on their labs. Your basic metabolic panel and a blood gas will tell you almost everything you need to know. You're looking for that classic signature. The pH is down, the bicarb's in the toilet, and the anion gap is wide open. And, of course, the lactate is way up. This pattern is the hallmark, the fingerprint of MALA. And when we say the lactate is elevated in MALA, we mean seriously elevated. It's not at all unusual to see levels over 15. To put that in perspective, normal is under 2.
Seeing a number like this in a patient on metformin should make mala scream at you from the top of your differential.
So you've seen the labs, you've confirmed the diagnosis. Time is absolutely critical. So let's run through the Emerala playbook. This is your immediate action plan. There are 3 essential life-saving steps. Number 1, obviously, stop the metformin. Number 2, you have to aggressively treat whatever pushed them over the edge. Resuscitate them from shock, start antibiotics for sepsis, whatever it is. And number 3, if the acidosis is severe, the definitive treatment is dialysis. And this does 2 crucial things. It fixes the life-threatening acidosis, and it physically pulls both the lactate and the metformin right out of the blood.
Okay, last section. Let's cover a really crucial update. The old way of thinking was that if a patient had any kidney disease, metformin was a hard no. Well, the modern guidelines are a lot more nuanced.
Now, we base the decision on the eGFR. If the eGFR is 45 or higher, it's generally considered safe. If you're in that gray zone, from 30 to 44, you can use it, but with caution. That means a lower dose and closer monitoring. But if that eGFR drops below 30, metformin is contraindicated. End of story. So if you're trying to remember the why of all this, just burn this sentence into your brain. Metformin pushes metabolism toward lactate, and it blocks the body from clearing it. It's a perfect metabolic trap. And that perfect metabolic trap turns into an absolute catastrophe in patients with CKD. Because when the kidneys aren't working, you get a double accumulation. The drug accumulates, making the trap even stronger, and the lactate accumulates, which is the crisis. So, I'll leave you with this last thought, a crucial question. Right now, think about your patient list. Who has that borderline kidney function? Who has heart failure? Who's at high risk for getting sick? Which of your patients on metformin needs their dose or their kidney function reviewed today?